everybody. This is Dr. Lori Shemek.
And I'm Omar Cumberbatch. You're listening to This Podcast Burns Fat. Hey, Lori, how are you today?
I'm doing great, Omar. How are you?
Well, just so the audience knows, this is like our fourth take of this. So
It's
this is,
hilarious. Oh
yeah, I
my
think
gosh.
we're definitely in Super Bowl mode, right?
Yeah,
So
right.
yeah,
Exactly.
it's Super Bowl Sunday as of this recording.
Oh my goodness. I have
So-
tears rolling down my face.
oh
Oh,
man, yeah, this one's
yeah,
tough,
I know.
but all good. We're gonna get through it. So today is
hmm
a fantastic. I'm very excited to share him with you and then the audience.
Yes, Dr. David Amron is in the house, and seriously, it's such an interesting topic because he speaks about lipedema and not lymphedema, but lipedema. And he says that so many people think they're overweight when in fact they have this condition.
Yeah, it was really fascinating. Even people who've lost like a lot of weight, who may have gone through
hmm
uh, gastric bypass surgeries, they still don't like lose it in the areas that this condition affects, which is really fascinating. And he just brings light to it. And he's done many, many surgeries on this. And he think, at least in this country, he's one of the leaders in this kind of treatment.
Right.
And it's really just good to know that there might be an issue that's going on that we're just not aware of, right? And I think
Yeah.
that's what he was doing,
It's
is really shedding light on that.
yeah, and thinking that you have so much weight to lose when in fact it could just be this.
Yeah.
So interesting.
Yeah, so listen, let's jump into it.
Okay.
Hey, Dr. David, how are you today? Welcome to the show.
Great, Omar. Nice to be here. Thank you so much.
Great to have you today. What an interesting, unique topic we have here. And it was interesting. We were talking, and I even got the name of the topic wrong. I thought it was about lymphedema, and that's not the correct name at all. Could you educate us?
Yeah, it's always good
Yeah,
to have
well,
like new topics. So I just wanted to give you some props, Doc. I appreciate you introducing something totally new to our
Yeah.
no,
audience. So I appreciate that too.
sure. And that's it's such a great starting point because actually that's one of the big problems with this disease. It just literally got glossed over. And I've said for so many years, I think it was given a poor name, lipedema. So for those listening, it's lipedema, lipedema, and it commonly is either mispronounced like lipoderma, or many people confuse it, including doctors, with lymphedema, which is a separate disease and condition. And the irony is a couple things. First of all, it's twice as prevalent, apparently, as lymphedema.
Wow.
And it was initially, and I said this many times, initially defined very well in 1940 at the Mayo Clinic. So a long time ago. There were
hmm
some beautiful papers written about it in 40 and 47 by authors Allen and Hines. They really nailed it, but it just literally got glossed over and never got taught in medical schools. And again, I've said that when you don't learn a disease in medical school, years later, when you hear of some disease, you think it doesn't exist because you never heard about in medical school. And lipedema was that way. I also think the name, like I said, is a little bit of a weak name. We should have maybe called it something else, Allen-Hines syndrome or lipofibroedema.
hmm
Um, so that's the whole kind of story about lipedema. Most people don't know about it, and unfortunately, most doctors still don't know about it.
Well,
And
what
it's
should,
commonly just
oh, go ahead.
yeah. Go ahead, Lori.
I was just going to say, what should we know about it? I guess what is
A
it
lot.
is, yeah.
Yeah, a lot. So I guess starting with what it is. So it is a fat storage. It's characterized as a fat storage condition, but we're going to talk about it a little bit. It's not only
hmm
just a fat disease, it's a disease of connective tissue and swelling and inflammation, the pathophysiology of it. It presents typically around puberty is when it begins to show up with hormonal changes. It virtually always runs in families. This pattern of inheritance, as a physician, is called autosomal dominant, where you pick up the gene
hmm
directly from a parent. And in equal frequency, a mother or father could be carrying the gene, But if the dad's carrying, like I say, he's not going to express it very often. So you got to look at females on his side, his mom, his sister, for evidence of it. And it gets progressively worse throughout a person's lifetime. Usually will increase with activity of hormonal changes of puberty, pregnancy, menopause, or OBGYN surgery. And this is the important thing, essentially unresponsive to diet and exercise. So patients are commonly, when they're young, just misdiagnosed or misunderstood and just told to go lose weight, eat less, exercise more. They're told by family, by friends, they're shamed, they're blamed, physicians miss the diagnosis. They get down the rabbit hole of weight loss therapies. About a third of my patients culminate with weight loss surgery because they have been literally misdiagnosed as obese based on BMI indexes. They get weight loss surgery and they'll lose some weight, but the areas of lipedema don't change at all. So what does lipedema look like? It's diagnosed based on three areas: our characteristic signs of lipedema, our symptoms of lipedema, and then again the family history. The signs are that it has a characteristic look to it. These patients are disproportionate. They tend to have very thinner upper bodies and torsos, and they got more fullness in their legs in a very characteristic pattern that goes from the groin calmly down to the ankle area. Many times there's cuffing of the ankle, so commonly the calves and ankles are involved. The arms
Is it
eventually
obesity? Does it look like obesity from the waist down?
well, so obesity to me just means overweight. And that's again one of the problems is the patients are commonly just simply
Mm-hmm.
characterized as obese because they are overweight for the most part, but it's the disproportion that is the important factor. So you're right. They've almost like got obesity from the waist down. Many patients have bony, skinny upper bodies, and they've got huge legs down to their ankles. They got weight loss surgery. They might lose some weight, but the legs don't really change at all. So yeah, in a way, you can kind of look at that. Maybe it's looked at like obesity, being overweight in a disproportionate fashion in the legs and arms, and sometimes the upper buttock area. There's a characteristic tenderness to pressure, and that's something that's very different about lipedema, that other things don't hurt the way lipedema does. In most patients, they have pain to some degree, typically characteristic sensitivity to pressure. People say when I get a massage done, a pedicure done, my husband grabs me, my dog jumps on me, it hurts. They think it's normal, but it's really part of the lipedema. A lot of patients get misdiagnosed with fibromyalgia. Easy bruisability is common, swelling is common, and about 85% of patients have hyperflexibility of joints and variations of Ehlers-Danlos syndrome.
So
That
one of
is,
the,
yeah.
that's interesting because I think this is definitely more prevalent now than it was in the past. Are you noticing that as a trend, or people just be more observant to this kind of issue?
Well, sure. I don't think it's I don't think it's any more prevalent than it was 30 years ago.
Mhm.
It's just that we are becoming more aware of it because remember, it's a genetic disease. So the genes are there. I mean, the genes have always been there. It's just that we are now beginning to become more aware of it. But still we have a long way to go. I mean, I would say that I've been involved in this for over 25 years with lipedema. Back over 20 years ago, almost nobody's heard of lipedema. Less than 1% of people are physicians. Now it's about 10%, but it's still the majority of people don't know about it. So it's more like an increasing awareness. And it's begun to be a hot topic on the internet. People
That's good.
patients are mostly searching for swollen legs or painful legs and coming across this term. And most patients that I see have in essence self-diagnosed themselves. They've just kind of things weren't making sense. They got on the internet, came across this. They see pictures that look like them, and they say, wow, I think I might have this disease.
I like
That
that
is,
you brought
yeah.
that up. Then sorry, Laura, that was
Yeah.
kind of was my follow up because I was just curious. Who basically makes that diagnosis? Is it a general practitioner? Do they actually go to, like I said, their primary doctor, or is it someone at your level who actually makes that kind of diagnosis? Because it is so misunderstood.
Right.
Yeah, so great question. Most patients come to me from around the country, and they commonly have a very hard time finding anybody to be able to truly diagnose them.
Mm.
And and so most of these patients, I would say 90%, the first question I ask them is, when did you hear of the term lipedema and how was that? And it becomes clear that 90% of these patients are really self-diagnosing themselves. Like I said, they get on the internet and they're kind of like, see pictures or it seems like lipedema. And so in essence, I'm confirming the diagnosis. So I'm typically the one diagnosing officially,
Mhm.
but they're having a hard time finding primary care practitioners, OBGYNs who are familiar with lipedema that can actually accurately diagnose. Now, things are beginning to change. It's getting a little bit better as time is going on.
That's fantastic. Yeah, it's so interesting. But I still wonder what the difference between, say, lymphedema is versus lipedema.
Right. So yeah, I mean, a good question. So again, different condition, lymphedema tends to have different types of lymphedema. First of all, usually lymphedema is unilateral in one leg or one side of the body, and typically lipedema is symmetrical and bilateral. So that's one very important just differentiating factor.
Hmm.
Lipedema tends to have a little more of a characteristic look in terms of how that swelling
Mm-hmm.
presents around the leg, of these patterns we call, or types of lipedema. It has more of the tenderness to pressure that lymphedema tends to not have. Um, and lymphedema is there. It's either congenital or occurs from trauma, whereas lipedema is more of a genetic disease itself. So it's really a very separate disease with a different presentation. The
Mm-hmm.
confusing thing is that lipedema, if left long standing because of the scar tissue that begins to build up because the inflammation chronically in the layer of fat, can begin to damage the lymphatics. And when that occurs, you get subsequent lymphedema in areas of the lower legs, but that is usually bilateral, and that term is lipolymphedema to
Oh,
differentiate
interesting.
from lymphedema.
Right.
So it gets
Yeah.
a little bit more confusing.
So, Doc, one of the things that you keep bringing up, and it's a very important point, is the genetic component to that.
Mm-hmm.
I guess what we would probably try to figure out at this point is that if we do believe in the epigenetic model, is there anything that we can do that doesn't turn on these genes that maybe lifestyle or diet can assist in that? And then if not, what's the next step? It's surgery, or what is the solution to dealing with this?
Yeah, so a really important question. So yes, there are a lot of things that patients can do to, so-called, not excite the genes and slow down the progression of lipedema. And this is why I've said for years that we have to start teaching this in medical school.
Mm.
I really feel that it should be a screening that goes on in teenage girls. It's not that difficult to diagnose. It's based on a characteristic look, symptomatology, and a family history. So really OBGYNs, pediatricians, family practitioners should be diagnosing it at a young age, because at that point you can begin a lot of preventative measures to really slow the progression of the condition, and the patient does not have to move into surgery. And those things basically fall into two areas. One is a respectful dietary strategy for lipedema. Now, I'm using those words very specifically because I'm not just saying dieting or eating less food. I'm
Mhm.
saying avoiding the triggers for lipedema that we know create more swelling, more disease activity, more inflammation, and perpetuate disease. So, and diets that generally avoid gluten, grains, sugar, alcohol, dairy products are diets that are respectful of lipedema. Diets that are more towards a ketogenic type of diet, avoiding grains, are generally more bring about less disease activity. So patients have to learn to eat properly for lipedema preventatively, and that's even the same after surgery too. We'll talk about that. So that's
And
one
that's
big
probably
area.
something unique, because a lot of times people I'm just assuming, I don't know, but most likely decades ago they just said go home and have your oatmeal and and hope for the best,
You're,
right?
you're right. I think that I mean, we've got I want to there's so many different dietary strategies, but I
Mm-hmm.
think that there's been a lot of, even people without lipedema, a lot of concern about a carbohydrate rich diet, and the importance of diets are they're less in carbohydrates, or the wrong carbohydrates, and that becomes especially true for lipedema. So yeah, years ago, we didn't know that. We do know that now, specific to lipedema. There's a whole chapter in my book about dietary strategies for lipedema. The other important area, Omar, is compression.
Mm.
Um, because patients with lipedema, kind of like lymphedema, but not usually as prominent, tend to have swelling. Actually, swelling is an important factor in the first part of what goes on with lipedema because it's occurring because of leakiness of lymphatic membranes where fluid is moving out. So controlling the swelling helps reduce the disease activity. So early on, patients should understand if they're having swelling, the importance of compression garments. They can begin with lighter compression garments. Those that have more aggressive swelling need stronger compression garments. And the ones that swell more will need to wear it regularly. The ones that don't have as much swelling can wear it intermittently. There's other types of therapy like lymphatic massage or manual lymphatic decongestive therapy by qualified trained people. The more advanced patients can do compression pump therapy. So compression therapy is also another important preventative dietary strategy. And ultimately, as the disease progresses, and if prevention is not working, and in some patients where it is more aggressive, despite their best efforts, the disease still will progress. Ultimately, properly done liposuction surgery, which is specific for lipedema, is the most important thing to set it back in its course and to kind of return it to where it really wasn't active at all with things.
Mm.
That's really interesting. It's just it's such I know it's such an awful condition, and so I'm just thinking, are there any outside of diet, any supplements somebody can take, any medications? I know a multidisciplinary type of approach is probably important, such as exercise as well.
Yeah, I think that, proper dietary strategy is important.
Mm-hmm.
Certain exercises, a lot of aqua therapy and water exercise are good for patients. Vibration plate therapy is good. But there are a variety of different supplements in different categories that can be helpful for lipedema in terms of reducing some symptoms. Some of them are anti-inflammatory, some are working for metabolism, some are working to support the lymphatic system. There's again a whole chapter in my book about the different supplements that are effective for lipedema.
Yeah, and the name of your book is
I've got it right in front of me here. Lipo, it's because
Yay.
it's a word, it's a mouthful. Liposculpture
I
and
know.
lipedema surgery, a guide for the patient and pearls for the surgeon. And I wrote this over about 2 years, and it's an interesting
Wow.
book because books are either, as you know, highly referenced medical textbooks for doctors and surgeons, or they're more very basic guides for patients that just don't get into too much meat about things. And this book
Mm-hmm.
kind of straddles both worlds. It's primarily a guide for the patient. It goes into a lot of educational stuff about liposuction, but it's also has all these boxes and pearls for the surgeon in terms of important considerations with technique. It's broken into 3 chapters. One is cosmetic liposuction, understanding the role of that. The next one's revision liposuction, fixing so-called botched liposuction, and the last huge chapter is on lipedema.
Yeah, that's
And
what
it,
oh, I'm sorry. Go ahead, Larry.
oh, I was just going to ask if is there any role liposuction has with lipedema? Is there any
Oh,
role
I
for
mean,
liposuction in that disease?
I I mean, I just literally, I'm sitting here out of a case, I finished about 15 minutes ago.
Uh-huh.
It's got a hugely important role. And I'm not just saying that because, certainly I do a lot of this, but it's very important for patients with lipedema to understand and to many times accept the importance of the role of well-done liposuction surgery because it's a singular thing that is the most transformative in a patient's life. Not only just how they look, but literally how they feel. I mean, many patients have done almost everything, including a lot of the preventive things we just talked about, and their disease progresses. And the liposuction is, I mean, it's life-changing for almost all patients.
That's great. You're like a lifesaver. I'm serious.
No, absolutely. And I'm
You
just
know,
Yeah.
I got to tell you, it really, it's such a blessing in my life because, I've said that I went into medicine to help people and I like science. And, I spent so many years in cosmetic liposuction, my specialization with that. And I began to do lipedema over 25 years ago. I was the first person in the US by far to do it on a regular basis.
Wow.
And now it's the vast majority of my practice. And I got to tell you, it's so incredibly gratifying because every day I have patients wrapping their arms around me. I have these big, huge husbands grabbing me and
Oh,
hugging me, what I've done for their wives. I would say that 3/4 of the patients or families cry during the whole journey because it's such a life-changing thing.
That's what I kind of wanted to give you some props to because I want to let people understand the extent of you've done over 12,000 liposuction surgeries. We understand it. I'm just curious, when did you make the link between the liposuction and this particular surgery that helps in that way? Was it something that you stumbled upon? Are you like the
Yeah,
originator of it? I was curious about that
yeah.
part.
Yeah. I get asked that a lot, and I am the originator of it, at least in the US. I began to do it over 25 years ago, but it came about because I decided in the mid 1990s to focus my entire practice on liposuction, that one procedure. And I began to get referrals of all these complicated types of patients, revision patients, and a lot of patients where nobody wanted to do certain areas of their body, like forearms and calves and ankles. And I developed techniques for doing calves and ankles that were very advanced and sophisticated and unique. And I began to get a lot of patients for calves and ankle surgery. And that's was really kind of a forbidden area with liposuction for no great reason. Most surgeons still don't do it. They'll say, oh, you can't do it, or risk of clot formation, or whatever it is, or compartment syndrome. So I began to engineer and design approaches to calf and ankle surgery. So then fast forward about 10 more years, I was in this makeover show with my old partner, Paul Nassif, on the Botch Show. It was a European show where he was doing all the facial plastic stuff, and I was highlighted doing these complicated liposuction surgeries. And I had all these European women coming to me saying, Dr. Amron, I have lipedema of my legs. I want you to do my surgery and and help me with my disease and make it beautiful. And I'm like, lipedema? I, you know, I never really heard of this disease. I mean, you just have fullness in your calves and ankles the way I do it over and over again. And that's when I began to realize for all those years, all those patients I was treating with calves and ankles, the vast majority of those patients had lipedema. So it was kind of a perfect marriage of my skill set, patients having nowhere to go for people doing calves and ankles. And that's how that whole kind of relationship came about. And I just built upon that.
No, that's a good story. I'm also want to give Lori a lot of props because she's like the inflammation queen. I was really curious about how did you also discover that removing the fat through liposuction can be beneficial in lipedema? You know, so like was it really just a matter of the fat being inflamed to such a degree that caused this issue, or was it something else on top of that that contributed to the overall condition?
Again, another good question. I'll try to not go into, too much, scientific detail, but when I began to do a lot of these patients, you first, besides the presentation of how they look and the disease, and yes, a lot of them have pain and this, when you go in there, the tissue is quite different. There's a lot of important differences with these patients. These patients are very fibrotic. They have a lot of
Mm,
scar tissue in their layer of fat, either
mm,
dense or nodules or strandy. And so it's that scar tissue is occurring, as we know, scar tissue occurs because of chronic inflammation. And so inflammation plays a big part in lipedema, and it's one of the important things that really makes it so different from just typical cosmetic liposuction, the ability to understand how to deal with the inflammation and fibrosis as part of lipedema.
mm.
To then add to it, the piece of the puzzle began to take place over the years with different research that began to come in about the disease of lipedema. And one of the things was showing in 2016, there was something called radionuclide studies, which trace cells and show that in lipedema patients, these cells are moving across membranes into layer of fat, developing as early fat cells replicating. You get inflammation through replicating fat cells, and that begins a process. So it kind of goes back to, what's causing lipedema. The problem is actually not the fat. That's the really weird thing.
Mm.
The fat cells, I feel, are essentially normal young fat cells. In fact, I use them commonly for fat transfer because you're not transferring the disease. The problem is the connective tissue, the leakiness of lymphatics. And that's what that 2016 radionuclide study showed. These patients have leaky lymphatics, fluid is moving out. And then you get inflammation. But Lori, the inflammation is not autoimmune. It's not primarily lymphocytes, as I thought years ago. It's what we call
hmm
macrophages, or cleaning up the dying off fat cells.
It
But
seems though that the fat cells would be affected in some way, correct?
Affected. Well, what
Inflammatory,
so what
leaking,
seems to go on is that their turnover happens so quickly that they can't support their growth, and they begin dying off, and then the inflammation
Mm-hmm.
starts walling them off with more fibrosis and scar tissue around them. We're still trying to characterize the cells themselves. About 10 years ago, I very carefully, and I got to be honest, I was a little bit concerned the first time I did fat transfer on a lipedema patient. This is how sometimes breakthroughs begin to take place in understanding of things.
Is
You
this more
think,
like, is this similar to like a gut transplant? A gut
no,
microbiome?
it's really similar to simply just a fat transfer, which goes on in
Okay.
cosmetic medicine, either to breasts or buttock or even the face,
Mm-hmm.
which I did a lot of I do a lot of cosmetically in patients. And with lipedema, I very cautiously began to do it in patients over 10 years ago. Now I've done hundreds of patients with fat transfer, and never once has a disease process been transferred to the new area. In fact, the fat cells work
Interesting.
perfectly. And that's very interesting because, as I've said, I don't think the problem with lipedema is really the fat cells themselves. It is a multifactorial problem involving connective tissue that's weakened. A lot of these
Mm-hmm.
patients have leaky gut syndrome or Ehlers-Danlos with hyperflexible joints or brain fog or other things that point to weakness of connective tissue. And then the inflammation plays a role in it too. So that's another factor that goes on. It's not just as simple as it's just a fat disease itself.
Right. That's extremely interesting, Dr. David. I would love, though, for you to kind of guide somebody. What advice would you give to somebody who who might suspect that they have a lipedema issue and they haven't been diagnosed or treated yet? What would you say?
Yeah, I would say the first thing is if they suspect they may have it, and why would they even suspect they may have it? I mean,
Mm-hmm.
commonly these patients just diagnosed as being overweight. But a lot
And
of times,
they
again,
themselves think they're overweight generally.
well, commonly, yeah, but sometimes no. There's different
Mm-hmm.
stages of lipedema 1 through 4, and if you look, through my book or on even the internet, you'll see examples. Stage 1 patients can look essentially almost completely normal. They could be 5'6" and weigh 120 pounds and have stage 1 lipedema, but there's a subtle fullness to their entire leg that wraps around the whole leg. It begins to lose the contour of the leg. The leg begins
Mm-hmm.
to look a little bit column-like. So it can be a very subtle diagnosis sometimes. The degree of pain is not always related to the severity of the lipedema. A stage 1 patient can have extensive pain. So I think if a person thinks they may have it, or just even curious about it, I would say quite honestly, any person who's just simply been diagnosed or thinks they're just overweight, especially if they had a frustrating time losing specific areas of disproportion, especially the legs, and now
Mm-hmm.
maybe the arms or body's disproportionate, they should look to see if they have lipedema. And there is a lot of very good information online nowadays, as
And your
opposed
book.
to years ago. And my book, I
Yeah.
think my book is actually a great guide. I think it's very understandable. It goes for a lot of discussion about the diagnosis of lipedema. I've also got websites too. My own website, David, what is it, Dr. Amron, MD.com, and
Mhm.
Advanced Lipedema Treatment, the Roxbury Institute. But there's a lot of good information online. It's not only just my stuff. And patients should go and research lipedema, and they should look at characteristic pictures of lipedema, because a lot of it is a clinical diagnosis by the way it looks. They should begin to relate to the symptoms of lipedema, the pain, the swelling, the hyperflexible joints, and then also, family history. Does it run on their mom's side, or the female side, or dad's side? Um, so, and usually, I got to tell you, the patients are almost able to self-diagnose themselves. Now, that should be confirmed by somebody, an expert.
Mhm.
But you know, when patients go on a line and they come across lipedema and they think they actually have it, they're usually right about it.
Wow.
So, Doc, one of the questions that it popped in my head is there a specific demographic that has more lipedema than that presents itself more that you've noticed, or is it just across all demographics?
Yeah, another very good question. I have seen every single demographic from Caucasian to Black to Hispanic to Middle Eastern to Asian. So it really is across every demographic. I would say that if there's one group that seems to be less common in, it's probably purely Asian, Chinese, Japanese. I would say I've seen less lipedema in Asian patients than in the other ethnicities.
Okay. That's very interesting. Yeah, it was just something
Yeah.
that popped in my head as
Hmm.
you were discussing it.
So, Dr. David, what like in your experience, are there any misconceptions or myths surrounding lipedema that you'd like to dispel?
Well, the main one is it's just simply commonly missed and misdiagnosed as being either being overweight or obesity.
Hmm.
That's the main
Okay.
thing. I think that it's just that's its most common misdiagnosis. It's just literally just thrown into a category of being overweight and obesity. And that goes back to the problem with something I've been saying for many years, which is this archaic index that we all seem to put way too much credence in, which is the BMI index.
Mm.
To me, the
It is
BMI index.
wrong. I know. I agree with
Thank
you.
you. Thank you for saying that. And you know what? In the last year, I'm starting to see all these different articles coming out about the BMI index being wrong. And I've been saying this for years, and I think it's a ridiculous index, honestly. It characterizes
Hmm.
people's height and weight, says nothing about disproportion.
Or muscle
Um,
mass.
and or muscle mass, exactly. It's the most silly index. And do you realize, Lori, I looked into this, the history of the BMI index goes back almost 200 years, and actually
No.
was never, yes, in the early 1800s, it was never developed to really be used in medicine. It just was an epidemiologic thing. And then all these medical studies began to come out about BMI indexes. And listen, I don't want to get into a touchy area here about, surgeons and many others just, clinging to it in terms of
Hmm.
safety things. And then you've got studies that support BMI index, and you cannot do surgery or a patient that's 40 BMI. And the problem with lipedema, a lot of these patients are over that, and they are literally like just in a corner with things because surgeons won't operate on them because their BMI is too high. Or what they do? They tell them to go either lose weight, which they can't do, or go get bariatric surgery to drop their BMI to some acceptable number so that the surgeon feels comfortable doing orthopedic surgery on them, when instead they should have done either diets for lipedema or liposuction surgery. They get bariatric surgery done unnecessarily. It's covered by insurance to add insult to injury for the wrong diagnosis of obesity when their primary diagnosis was lipedema and they became secondarily obese
Oh,
because of
that's a
lipedema.
crime. That is a crime.
It's just ridiculous. So again, another group that needs to be educated on lipedema and really be screening and triaging patients are bariatric surgeons. And I'm sure that, a lot of your, audience maybe are bariatric surgeons listening, but they really need to understand lipedema. And I would say every single patient that they're doing weight loss surgery on, they should screen that patient for lipedema. And if it's lipedema, I'm just going to generally say bariatric surgery is not their first treatment and may actually have very little of any role in these patients. They should start on preventive dietary strategies for lipedema. And this is not a self-serving thing, but my strong opinion is that liposuction surgery should be done first before bariatric surgery, correct the disproportion, decongest areas, treat the lipedema. And you know what then miraculously happens? The patient then, their metabolism improves mostly always, and they then begin to lose
Hmm.
weight in other areas. And you know what? They usually don't need the bariatric surgery. And they've saved themselves
Wow.
and the insurance company and the potential risk of bariatric surgery for the patient. Like I said, about a third of the patients I see for consultations have had bariatric surgery, and it's always the same story. Yeah, I lost 50 pounds, 80 pounds, 100 pounds, but I lost it where I didn't have lipedema. My lipedema didn't change at all. And everybody else is saying, well, aren't you happy you lost 100 pounds? But this patient's saying, but yeah, but my legs are the primary problem, never changed one iota, or I'm still in as much pain. And then,
Mm.
everybody scratches their head wondering what went wrong. And that patient then goes on the internet and then makes sense of the story themselves because things were not making sense to them.
So, Doc, I hate to give like that last question, but in this theme right now because I know it's going to open up a can of worms, especially because you mentioned the insurance companies. Now, this surgery that you provide, the liposuctions and the
Yeah.
like, is
Fat
this
transfer.
yeah, the
Yeah.
fat transfers, all these things that can prevent the, like they said, the big bariatric surgeries that are unnecessary, it seems. Like, are they covered first? I was like, or is it something that's
Well,
going to be problematic where they have to come out of pocket to get
well,
these
yeah,
kinds of
another
things to learn the lesson the hard way?
yeah, so another good question. And the quick answer, unfortunately, it still is a challenge.
Mm,
Things are beginning to change. I'm very involved in insurance reform for lipedema surgery, and we are making advances and having great wins go on. And this is so much different than it was 8 or 10 years ago. And but still, it's a battle with the insurance companies. They are now beginning to recognize it as medical necessity, but it still is a challenge. I'm in network with a couple of major providers, which is a huge win with things. The
mm,
other ones we battle the insurance companies, but unfortunately, a lot of times the patient has to pay up front with it, and then we try to work with them to try to get it covered afterwards. But it's still a battle and it's still a challenge, and things have got to continue to change. The fat transfer part, Lori, no, that's never part of it with the coverage with lipedema surgery. That purely, I want to be clear, that's purely a cosmetic thing. I mean, that's not
Right.
part of the treatment of lipedema.
Right. Right. I know that. Yeah. But it is a treatment. It does. Am I correct in that?
No, no, the
It,
way no, the way I use fat transfer if I'm doing a lipedema patient, and this is maybe once a month or so, if they've got uh, lack of fullness in their breasts and say, doctor, I don't want to do breast implants, could I do a fat transfer? I will use their lipedema fat for that, but that is purely a cosmetic thing.
okay. Got
So
it.
it's not
That
it's
makes
the
sense.
fat transfer is not really part of the treatment of lipedema. I use it in my revision work to fix problems and irregularities, but it's not part of the treatment of lipedema.
Okay. Great. That's wonderful.
gotcha. So, Doc, you've been fantastic. I mean,
Oh,
I know I
yeah.
learned a ton of stuff. I know I was
Same.
firing some crazy questions at you, and I appreciate
No,
your
it's
patience with us. But I
good
do want
questions.
to, keep following up with this topic. I think it's great, and I know that a lot of people have other questions regarding liposuction we didn't get a chance to dive into, but maybe down the road we can have you back to dispel some of those myths. And I know liposuction is a great topic as well. But in the
Mm-hmm.
meantime, can you give us your social media handles, your website, anything
Yeah,
to keep up with
yeah.
everything,
Let me
and
see.
your book,
I
of
got it
course.
written down here. So my websites are Amron, MD, AMRONMD.com. Another one is Advanced Lipedema Treatment.com. You can find me on Instagram, David Amron MD, and also the Advanced Lipedema Treatment. And then my book is available on Amazon and Kindle, I think also. It just got released last month. It's a great guide with things. And yeah, I mean, I would love to actually at some point come back and talk a lot about what is different about liposuction for lipedema specifically, because that's a huge question.
Mm-hmm.
What's really different about it? Why isn't it just normal liposuction? I mean, why do you have to really be specialized or even trained in it? And then what's different about not only just the surgeon, but the whole program? Because it's not
Yeah.
not just the surgeon, so it's a faceted program that I have here, which is really important because things have to be done properly. And this is an evolving area, it's a new area. And there's no kind of, yet really such defined standards and guidelines with things. That's an important thing for patients to understand.
Well,
Well,
appreciate
that's,
that.
yeah, you've been absolutely fantastic. And I know
Thank
you
you. You
helped a
guys are
lot of
great.
people. You've got them further down that road, that journey to just resolution of their condition. So thank
Yeah,
you.
yeah, it's
Thank
great.
you.
I love it. Love it.
Yeah.
All right, guys, listen, thank you so much.
Okay.
Happy holidays.
Take
Okay.
care and
All
thank
right. God
you.
bless.
Happy
All right.
holidays.
Yeah, take
Okay.
care.
Bye
Nice
bye.
talking with you.
Same. Bye bye.
Thank you so much for listening to this episode of This Podcast Burns Fat. We're so excited to have you as a listener, and we're hoping that you've really enjoyed the content as well. And if you did, please run over to iTunes and provide a rating and or review. It will go a long way in helping us continuously build our listenership up so that we could provide you with excellent content regarding fat loss, weight management, and just an overall healthy lifestyle. Thanks so much. Have a great night.